Hi, everybody. Welcome to Community Nursing. This is going to be our first pre-recorded lecture. We'll meet on Wednesday to go over some other things. What we do for our pre-recorded lectures is I'll go through your PowerPoints with you and for your reading. So we start with community-based nursing. There's two different types that we want to look at. We have community-based nursing, which is where you focus on the illness care of individuals. And then we look at community-oriented, where we look at the quality of life and promoting that, and healthcare of entire individuals and populations. This includes our specialty of public health nursing, and our goal is to prevent disease and preserve, promote, restore in the community. We take a look at what is public health. Our goal is to organize community efforts that will use scientific knowledge to prevent disease and promote health. We have our benefits that decrease the number of deaths from stroke, coronary heart disease, cancers, declines in death rates of adults and children, and we have population-focused approaches that can help with us in America. Public health, again, our practice provides many benefits. Imagine how many more benefits the United States might see if more money was given towards our public health practice, which is something that we will talk about. So we look at our levels of healthcare. We have our population-based at the bottom, then we have clinical preventative. We have our primary healthcare, secondary, and our tertiary is at the top here. So when we look at our public health, we monitor health status to identify problems, we diagnose and investigate problems and hazards, inform, educate, and empower. We develop policies and plans, enforce laws and regs. We ensure a competent public health and personal health care, evaluate effectiveness, research for new insights and new problems. We look at public health nursing with population focused and community oriented, and we have our health and prevention focused interventions at the community and population level. We have concerns for the health of all members of our population, particularly our vulnerable population. So we have our population focus, where our focus is on providing services to individuals rather than a population. Some examples would be our screening that we do of kids in preschool programs to evaluate. And then we have our individual, family, and group focus, where we emphasize health protection, health promotion, and disease prevention. And we are going to look at our community-based versus our community-oriented. So our goal with our community-based, again, is managing those acute and chronic conditions. Focus is on illness care. We're going to provide acute and chronic illness care and the provision of comprehension and continuous care. And then we have our goal with our community-oriented nursing to prevent disease and disability, and really on the health care of individuals, families, and groups. We have our three key nursing modes in the community that we're continuing to talk about. We have public health nurse practice, which our goal there is to prevent disease and disability again, and the community as a whole is how we look at it. Challenges for our future: we see current trends to move more care into community settings, reduce the number of hospital days for sick clients. We know community care can be less expensive than our acute care settings. The trend is expected to grow with the role of the nurse in the community and will likely change. So that's our chapter 1. We're going to take a look now at our chapter 2. And that will take on our history of public and community nursing. So we take a look at that, and we are going to look at early public health. We know people and cultures have been concerned with the events surrounding birth, death, and illness. For a long time, we have ability to preserve health and treat illness. We have examples from our ancient Babylons, our Egyptians, and our Industrial Revolution, and how that changed with public health care. At first, it was a family-friend system of care. First hospital was founded in 1751. We saw several epidemics during 17th, 18th, and 19th centuries. We have some reports that we looked at. We know organized nursing practice and education in hospitals. We saw Florence Nightingale. Direct first nursing school opened in 1870. We know we had the VNA, or the Visiting Nurse Association, in 1885. And then we had our first African-American public health nurse, Jessie Sleet Scales. American Red Cross and rural nursing services were things that we looked at and took care of. Occupational health nursing, we saw Stewart to do that, and school nursing with Lena Rogers. We look at our continuing growth of public health. In 1909, we had a program to look at Visiting Nurse Quarterly, and then we traveled on and did some different things, had a national organization for public health founding, and then 1920s and 30s, our nurses continued to assume leaderships in public health, such as in Orange County with the typhoid epidemic. Some health that we saw during World War I, we had the 1918 influenza pandemic. MetLife also in 1909 recognized public health nursing. In 1921, we had the Maternity and Infancy Act, also called the Shepard-Towner Act, which gave money to moms prenatally, taking care of that. We had a Frontier Nursing Service, and that was going to be during our with our Frontier community. Some challenges we saw with African American nurses in public health nursing. We did see segregated nursing education until the 1960s, and that lower income in the South. We looked at our economic depression and public health, 1930 depression, decreased funding for nurses' services. 1933, we had our first nurse employed by the Public Health Service. We had Social Security Act of 1935, the Bolton Act of 1935. We know from World War II until the 70s, we had our National League of Nursing, American Nurses Association come, a nurse practitioner movement in 65, and American Association of College of Nursing was established in 69. So now from 70s to the present, we had the hospice movement in 1970. In 79, we had the Healthy People Initiative, which will be a big piece that we look at is now Healthy People 2030. 1985, we had some research that continued and established. Institute of Medicine and Public Health was seen in 1988. Affordable Care Act of 2010, which is where we were giving health care to everybody to make sure that they were insured. We look at COVID-19. This was one of the epidemics that we've all lived through. I'm not going to go through this as everybody has gone through it. We look to the future. We seek to learn from the past, avoid pitfalls, plan for futures are made, and healthcare challenges are acknowledged so that we can do so. All right, we continue on, and we're going to look at our next chapter. And that is going to be on chapter 9, which is going to be about our evidence-based practice. Everyone should be familiar now with evidence-based practice from some other classes. But we'll take a look at our evidence-based practice. So we know research is evidence-based, and we do a scientific basis for practice so that we use our research to support practice. Nurses at all levels can be involved with evidence-based practice. We need more guidelines in public health for sure. We have evidence-based medicine, evidence-based public health, evidence-based nursing, and evidence-based practice. We look at our history that goes back from the 1970s, and we now know that we have current literature that focuses on our acute settings. We look at our hierarchies of evidence. So our highest level of studies that we will look for are going to be our double-blind randomized, and they're our highest level of evidence. Sometimes they're difficult to perform, though. So we will take a look at in class different types of evidence. Factors that we think about when we're implementing evidence-based practice, that an ability to interpret it, our philosophy around it, our availability of resources, links to outside support, and some lack of relevant and timely public health practice. Steps in our evidence-based practice, we have step 0, which is curiosity about the interventions. So we develop a question, we do some literature research, critical appraisal of the evidence, and then look at our outcomes. We do our systematic reviews, which are really good. They're a combination of studies to see what has come out. And then we have our meta-analysis as well. So when we're looking at evidence, we look at evidence based on the quality, the number of design studies that have looked at the information, and presence of similar findings. 3 domains, we look at quality, quantity, and consistency. And we evaluate quality of evidence to make our clinical decisions. So we're going to look at who's our randomization, who's our sample, how big is it, what was the intervention, how was the follow-up, and other variables. We look at cost versus quality sometimes, appropriate evidence-based method for community-oriented nursing practice. We use our internet for evidence-based data, but please be careful to our sources that we use. We are going to talk a little bit in class about Healthy People 2030. So this was a program that came out where everybody was looking to have health improvement across the large United States community, and we have direction and focus for measuring progress of improving health status within a certain amount of time. We have the Minnesota model, which I'm not going to spend a lot of time on, and that will be in your book to follow up on. And the last chapter that we're going to take a look at is going to be chapter 23, and that is going to be about our vulnerable the health and wellness of our vulnerable populations. So when we do this, we're going to look at our reading, and we know that during 2020, with the onset of COVID-19 pandemic and riots, the importance of equity and inclusion was highlighted. Select population groups were at greater risk than others with poor outcomes. So we're going to look at health equity. We know that this is ongoing. I'm sorry, it just told me to stop sharing. So go back to you guys, sorry. So we look at health equity. Everybody has a fair and just opportunity to be healthy. We have our American Public Health Association. We look at a cross-sectional and no health inequalities or barriers that prevent individuals and populations from getting maximum health. And we're going to take a look here at our determinants or social determinants of health. So our health determinants are a range of individual characteristics and behaviors that are going to influence our health outcomes. So we know we have social determinants of health, the conditions in which we're born, grow, live, work, and age shall shape health. World Health Organization identified 7 factors, and Healthy People 2030 have identified 5 domains of social determinants and health disparities. Healthy People 2030, especially relevant to a discussion of vulnerable population, because these are underserved and disadvantaged populations. When we look at vulnerability, we look at susceptibility to actual or potential stressors that may lead to an adverse effect. So we have our vulnerable populations, these groups with increased risk for adverse health outcomes. We'll look at risk and resilience. With our vulnerable populations, we're more sensitive to risk factors because they're often exposed to a bunch of different risk factors. To look at limitations in physical and environmental resources. Example, when we see poverty, we see poorer health outcomes, limited social support, access to healthcare, and working in a hazardous environment under our poverty. We have personal resources like level of education, and we have vulnerability often has a cycle, so it'll go along in a family. Special needs groups, we have age, both at the beginning and the end of the age, military, veterans, and people with disabilities. We know that with our vulnerable population, we've had the Social Security Act of 1965, Medicare and Medicaid, a balanced budget, temporary assistance for needy families, and some other trends we see: providing more comprehensive family-centered services, social justice, case management. All these are going to. Now we take a look at levels of prevention is going to be a big topic in our class. So there's 3 different levels of prevention. We have our primary, which is going to be our prevention. It'll be preventing things from happening. So we look at vaccines because that's going to prevent anyone from getting the flu. Then we have our secondary, where we do all our screenings like mammograms, TB screenings, all that kind of stuff. And then we have tertiary, where we're doing our treatment. So we'll do therapy groups for mentally ill adults. So we'll spend some time doing that and thinking about that as we go along. Some assessment issues. We have socioeconomic resources. We have socioeconomic resources, preventative health needs, and amount of stress, our living environment and neighborhood. And then we look at planning and implemented care. We have to create a trusting environment, show respect, compassion, concern, careful with your assumptions, focus on prevention, know when to walk beside the client as opposed to walk ahead, and know what resources are available. We're going to develop social networks as well for our vulnerable populations. So very important to remember all of these when we're looking at our vulnerable populations. We will talk about some of these topics during lecture this week. Please make sure you read your announcements, as that will help guide you throughout the week. And I look forward to meeting everyone on Wednesday. Take care.